Thank you, Sanya and Samosa. I'm going to hand it over to Dr. Yogesh Joshi, Director of the India Center.
Thank you. So good afternoon, everyone. On behalf of the India Center, it is my great pleasure to welcome you to our first annual India lecture of this semester, titled Ancient Wisdom, Modern Medicine, The Legacy of Indian Neurosurgery. The UCF India Center is an incubator of ideas, education, research, and enterprise on India. It builds academic bridges, enhancing cross-cultural understanding and connecting communities across India and the United States. Today, we have the honor of hearing Dr. Varindera Paul Singh, a distinguished pediatric neurosurgeon and immediate past president of the Indian Society of Pediatric Neurosurgery. His talk on the history and the contemporary landscape of neurosurgery in India promises to weave together a rich traditions of medicine with cutting-edge modern practice, engaging both experts, all of you, but those like me as well, who are also called doctors, but of philosophy. I would like to thank Sanya from Samosa and the entire Samosa team. Thank you so much. And Dr. Ed Ross from UCF for their invaluable contribution to organizing this event. And I extend our deepest appreciation for Dr. Yogi Patisabu, a renowned pediatric neurosurgeon who has been associated with UCF in many capacities. He's not only a true friend of the India Center, but also for me personally, a trusted mentor and a guide in the community. We are all truly delighted to have you all here. Without further ado, let us begin. I will now invite Dr. Ed Ross to say a few words. The floor is yours, sir. Thank you.
Okay, hi everybody. Ed, Chair of Medicine here. So we have M1s, raise your hands. Other M's? Excellent. Okay, so I'll start with my first slide. Only kidding, we're out of time. But I do want to say a couple things that I think are important. So as you go through med school, graduate, maybe faculty, you'll hear about our tripartite mission: education, clinical, research. Sometimes we'll add in service, right? But sometimes as students, you may not realize that there's another element that's very important, not just for academia, your career, but for science, and that is the goal of having impact. And UCF is all about impact. So here is your role model, the tripartite mission, and he's here today because of his impact. So it's not just Orlando, Central Florida, regional, national, global. So I can't think of a better role model to talk to us today. So welcome.
Friends, we're honored today. We're privileged beyond belief. Dr. V.P. Singh is a world-renowned neurosurgeon who has led an institution of 4,500 neurosurgeons in India and subsequently has led the Indian Society of Pediatric Neurosurgery. I've had the great privilege of working with him for the past 2.5 decades. Passionate, knowledgeable, dignified, and a tremendously effective speaker who carries the weight of how to move neurosurgery forward globally. I have heard him on the world stage of our national meetings here and other places. His technical skills are well surpassed by all the other things he does, and he still serves the patients in an excellent way. Dr. Singh, we are honored today to have doctors of one day. These people started yesterday. And I have in the back of the room neurosurgeons par excellence, board certified, and who have led the distinct group of neurosurgeons in town. So we have all gamut. So you're going to have a challenge speaking to everybody about this. Sir, we welcome you wholeheartedly, and we'd like to welcome you with our usual routine. Ed Ross and I will welcome you, sir. Thank you so much for coming and being part of our event. Dr. Ed? It's easier to carry than to. Right. So you have to have it. Dr. V.P. Singh, thank you so much for coming.
Dr. Ross, Jogi, Yogesh, and friends. It's a pleasure to be here, and apologies for being late. I think my Uber driver said you must see the main campus too. So I ended up there and had to rush here. But anyway, we'll try to get things going. So I'm going to be talking about pioneers of the mind, a history of Indian neurosurgery from Susruta to today. I'm sure a lot of you or most of you would not have heard of Susruta, so I'm going to spend some time trying to see how we can take it forward. This is the institution where I work. It's a private institution, and that's our operation theater, our cyberknife and the biplane DSA, and that is my senior team. So what I'm going to talk about is ancient trepanation in India, a bit basics about Ayurveda, Susruta surgical innovations, the initiation of neurosurgery in India, evolution towards modern neurosurgery, Neurological Society of India, and the impact on global neurosurgery. Whether you're first year or second year or whatever, doesn't matter. It's a very basic historical talk and how we went about doing what we did. So ancient trepanation or trephination of the skull is the surgical removal of a portion of the skull bone. It is one of the earliest forms of neurosurgery, predating even the written surgical texts. And the first global discoveries of trepanation are from Peru. So this is the earliest site of trepanation, and archaeological findings of skull with circular or rectangular holes have been dated to 2000 to 1500 before Christ era. And sites like the Paracas and the Andean highlands where these skulls have been found. Now, why were they done? We really don't know. We can only hypothesize. Could it be to treat trauma? Or in previous times, a lot of diseases was thought to be because the evil spirits have entered the head, and people did trepanation to let the evil spirits out. Or was the ritual? For what reason? We don't really know. So these are photographs of the skulls found in Peru. You can see the multiple trepanation holes, most of them circular. And what is important is there is remodeling of the bone, which means that these patients survived the surgery and had bone remodeled, which means they survived for a fair number of years. So the surgeries done by the Peruvian neurosurgeon, so to say, were successful. Another type of trepanation found in Peru, and this is the orthogonal cuts and to make a squarish opening or a rectangular opening. Now, in Kashmir, Burzahom, near Kashmir, 10 kilometers north of Srinagar, archaeologists have discovered a human skull in the 1960s with evidence of trepanation. And interestingly, when they date it, it is before 2000 BC, so it's older than the Peruvian. Similar skulls have been found in the Indus Valley civilization at Nothan and Kalibangan. Why were they done? Nobody knows. Therapeutic, magical, spiritual reasons, as found in other civilizations. And this is the skull excavated from Burzahom. You can see in the left parietal bone, you can see multiple burr holes, perforations, 6 of them. And you can actually see on the side there are another 5 attempted ones which have not worked out. And this has been documented that this was much before, at least a couple of centuries before the Peruvian ones. So it is likely that Peru was not the first site of trepanation. We have evidence even before of that in India. And how did they do it? There are 4 techniques. You can either scrape the skull, or you can make a circular groove on the skull and then cut it, or drill it with some means and then connect it, or rectangular intersecting cuts. Now let us come to Ayurveda. Now those familiar with Hindu mythology would say, there was a Samudra Manthan, which means a churning of the cosmic ocean. And the aim was to find the elixir of life. And to do this, the Devas, which are the gods, and the Asurs, which are the demons, they both joined hands to try to churn the ocean. And what emerged from that was God Dhanvantri carrying a pot of Amrit, the elixir of immortality or elixir of life. Now, God Dhanvantri is considered an incarnation of the Lord Vishnu, who is one of the Holy Trinity, Shiva, Vishnu, and So Shiva, Vishnu, and it'll come back to me. They are the gods of creation and Shiva, right? Sorry, Brahma, Vishnu, and Shiva, the gods of creation, preservation, and destruction. So Dhanvantri is depicted as having 4 hands. You can see one carrying the Kalash, which is the Amrit, and then the second hand has herbs in it, which is used for medicinal purposes. The third hand has a book, which is the Ayurveda book, and the fourth one has a conch, which is a symbol of Lord Vishnu. Now, as opposed to God Dhanvantri, there is a Dhanvantri, the divine healer. He lived between 700 to 600 BC. He was born in Kashi, the ancient city of Benares or Varanasi. He taught Ayurveda to his disciples, who included Susruta, and his association with healing and surgery lays the mythological foundation of the Indian medical system. So what does Ayurveda mean? Ayur is life, Veda means science. So it is the science of life. And it is one of the world's oldest medical system along with the Chinese one. More than 3,000 years ago, relies on natural and holistic approach to physical, mental, and emotional health. And it implements lifestyle interventions and natural therapies to provide a balance between your body, mind, spirit, and the environment. So what is the essence? It says there is energy or prana in the body which has to flow well and be in balance to be healthy. It recognizes that everybody's constitution or prakriti is different and many different treatments depending on which type of prakriti you have. The human body consists of tissues or dhatu, waste or malas, and bodily humors or doshas. And there are 3 doshas. Vat dosha, which is air-based, controls the flow in your mind and body. Pit dosha is fire, the energy which consumes, controls the digestion, hormones, and metabolism. And Kapha dosha, which is earth and water, what holds everything together. And each individual has a unique combination of doshas, and this is what defines the individual's temperament and characteristics. So these doshas dictate your emotional strengths and weaknesses, the foods your body wants and needs, and the exercises which are going to work well on you. So based on this, they said there are different types of individual constitutions, and you have to give the treatment according to the person's constitution. So when these 3 doshas are out of balance, illness occurs, and Ayurveda helps you to find balance between the 3 doshas to get you back to health. And this is Ashtanga Ayurveda, the 8 components of Ayurveda. Kaya Chikitsa, which is medicine. Shanakya, which is the orifices of the body, the ear, nose, throat. Agat Tantra, the toxicology, the toxins and the drugs and various things you have to treat the thing. Shalya, surgery. Kumar Bhritya, which is pediatrics, Bhut Vidya, which is microbiology, and the mental disorders, Rasayan, which is renovation, and Vajikaran, which are aphrodisiacs. So Shalya Tantra or surgery is the surgical arm, and it reached its peak under Susruta. Again, there are concepts of doshas, whose imbalance leads to seizures and tremors as written in the books. And concepts of maramas, which are high-risk anatomical zones, which you cannot touch as a surgeon. And instruments and cadaveric training was there. So this is Susruta, 600 BC, much before Hippocrates and Galen. He was called the father of surgery, and he did a variety of surgical techniques, and his seminal work is Susruta Samhita, which reflects his mastery of surgical techniques. So he was born in the 6th century in the town of Kashi. He practiced and imparted his medical knowledge as a disciple of Devodasa from the Gurukul of Dhanvantri, whom you remember was the earlier god. And he was empowered by the wisdom of his guru. He took a firm stand emphasizing the importance of anatomy and practical surgery through cadaveric dissection. We all do cadaveric dissections in our anatomical halls, but this started at the time of Susruta. He started doing surgery not only as a last resort, but as the most important and reforming feature in the field of medicine. And this is when he transitioned from a student of traditional medicine to a revolutionary who would change the very face of surgical procedures. He realized the importance of anatomy, and he faced significant cultural and societal challenges as dissection of the human bodies was considered a taboo. He remained steadfast that understanding the human anatomy through dissection was crucial for successful surgery, and he was able to navigate these obstacles innovatively, and that is why he transformed medical practice. His medicalist methods involved submerging bodies in flowing water to aid decomposition, and then he could examine them layer by layer. And he classified and described anatomy in comprehensive details, and he used models of clay, wax, and ghee, which is the Indian butter, to simulate human tissues and to practice surgical techniques. So you've got somebody who sort of actually made a model of the body parts so that the surgeons can actually practice the skills before they touch the human. How similar to what we have today. I mean, it's all AI generated now. You do it on the computer, but this is how he did it. So he wrote this book, Susruta Samhita, which includes surgery on skin, bones, soft tissues, cranial injuries. We'll come to those. He described various surgical techniques and described various tools. So this is the 8 types of surgical techniques that he described: excision, incision, scraping, puncturing, probing, extraction, draining, and suturing. And he labeled and described 121 surgical instruments, which he categorized in the yantras, or the blunt instruments, and the shastras, or the sharp instruments. They were crafted from iron and other metals with an emphasis on cleanliness and sharpness. He recommended regular sharpening and sterilization, again something we are all familiar with. And he had innovations in surgical techniques predating Hippocrates and Galen. So these are the blunt instruments. They are ergonomically made. Look at the shape of the instruments so that they are easy to handle. And these are the sharp instruments, scalpels to make clean cuts. You can see the needles and threads for effective wound closure. So coming to what he described, there was cauterization, application of heat to treat wounds and chronic pain, which sterilizes the wound, prevents bleeding, and promotes healing. He had the concept of bloodletting, removing excessive blood and balances body humor. Reconstructive surgery, rhinoplasty, was something he is well known for. And why rhinoplasty, you would ask? At that time in ancient India, a common punishment was amputation of the nose. If you've done something really bad, your nose was cut off so that everybody could see that you're not a good person. And he helped restore physical appearance and dignity. And for that, he mobilized the skin from the forehead and reconstructed the nose. So this is one of the earliest examples of plastic surgery where the forehead flap is still used today. He had concept of bone setting, proper bone alignment, sandhana, reduction, and splinting through bark, bamboo, or cloth. And post-treatment care was nutrient-rich diet, gentle exercises. So on basis of modern orthopedic techniques. Suturing and wound management, he emphasized upon wound cleaning, meticulous wound assessment, described interrupted sutures or continuous sutures and the post-suturing care. How did they do anesthesia? They used herbal anesthetics or opium and cannabis to manage pain. And they had both inhalation, oral consumption, and topical application. In his Susruta Samrita, there is evidence of cataract surgery, early ophthalmology, obstetrics and gynecology, cesarean section, urology, oral maxillofacial, and even neurosurgery. So his techniques were far superior for his time, and it's amazing how somebody in that age was able to do things. And he pioneered the art of suturing using horsehair and plant fibers. And it was his emphasis on precision, safety, and cleanliness which set new standards. What about his insights in neurosurgery? He had far advanced understanding of the nervous system as he describes his afferent and efferent nerves. The cranial nerves, for example, he writes, 2 nerves lower down at the back of the head, which if cut produce deafness, the 8th nerve. A pair of nerves inside the 2 nostrils, which if cut cause anosmia, the olfactory nerve. And a pair of nerves below the end of the eyebrow, which if cut cause blindness, the optic nerve. He was aware of the vascularity and he used cauteries to prevent exsanguination. So these methods align remarkably with early neurosurgical debridement, drainage, and even cranial trepanation. And these were all developed much before what we know from Hippocrates and Galen. So a few paintings showing Susruta in action, showing his anatomical expertise. A patient being operated after being given cannabis or something. And you can see the students around him learning it. And these is seen with herbs which is collected for treatment of the patient. And this is the Susruta Samhita, which has so many chapters, describes so many illnesses, which was written in the 5th or 6th century before Christ. Following him, in 400 to 200 BC sometime, we have another great sort of Indian doctor called Charak. And he was the physician. So it's interesting. The surgical aspect was developed much earlier than the physician. And he made a Charak Samhita which describes all these things. He primarily focused on the Kaya Chikits, emphasizing the diagnosis, therapeutic methods, disease prevention, medical health, and he laid the foundation of systemic clinical medicine, diagnostic reasoning, clinical observation, holistic treatment through diet, lifestyle, and medicines. And he is known as the father of Indian medicine, and Susruta is the father of Indian surgery. So he talked about manas, or the mind, and chetna, or consciousness. And he said these 2 are the factors which are central to health. And he described apsmara, or epilepsy, or umada, which is insanity. So these through 2 texts, Charak Samhita for medicine, Susruta Samhita for surgery, along with Ashtang Sangraha by Vagbhat, constitute the Brihat Triyad, or the great triad of compositions, representing a complete, holistic, ancient medical system. Interestingly, he also had a Charak Shapat, or an ancient Indian medical oath. And as we go through this, we find the similarities with the Hippocrates oath which came later. During the period of study, I shall live a disciplined life with my teachers and peers. My actions shall be guarded, service-oriented, free from indiscipline and envy. I shall be patient, obedient, humble, constantly contemplative and calm. And as a physician, I will always use my knowledge for welfare of mankind. And I will be ready to serve patients even if I am busy and tired, and I shall not harm any patient for sake of monetary or selfish gains. My dressing shall be decent yet impressive and inspiring confidence. I have to be appropriate, pleasant, truthful, beneficent, and polite, and so on and so forth. And if we compare the 2, the core ethical principles between the Charak Shapat and the Hippocratic Oath are very, very similar. Where it differs is that it does blend a bit of spiritual discipline with the medical ethics in the form of reverence to your teacher and taking care of them. Jivak is one more physician during the Lord Buddha's era, about 500 BC. He was a royal physician to King Bimbisara of Magad and also treated Lord Buddha. Takshila and Nalanda were the two famous universities where all this happened, and he was famous for performing advanced treatments, including cranial procedures described as removing worms from the brain, possibly an abscess drainage or trepanation. Post this, from the 3rd to the 16th century, the ancient medical knowledge remained preserved through Ayurveda and through these texts. They were translated into Arabic, English, and they served as a bridge between the global evolution of medicine and surgery. Now, coming to the colonial period, the Indians, we had interaction with the Europeans and had exchange of medical knowledge and surgical instruments. And in the 18th century, the British introduced Western medical education to India, and medical colleges were opened in Calcutta, Madras, and Bombay. Anatomical teaching and cadaveric dissection were revived. And in the early 20th century, some surgeons trained abroad in the UK or Europe and started performing basic brain surgeries. Specialization in neurosurgery in India had not yet emerged. So the formal neurosurgery actually started after World War II and in 1947, when India gained independence. At that time, there were no neurosurgeons in India. Neurology and neurosurgery were considered to be unimportant parts of medicine and surgery. And even though the first neurosurgical operations were performed by general surgeons in India in the 40s and 50s, the early pioneers were trained in UK, USA, and Canada, and they set up neurosurgery setups in Bangalore, Chennai, and Mumbai. Now, coming to the early development in India, the first was at the Christian Medical College, Bangalore. Now, interestingly, this had been started in 1900 as a one-bed clinic started by an American medical missionary, Dr. Ida Scudder. This was started about 150 kilometers away from Chennai or Madras. It was a small town. The aim was to provide health care to women and children and to train women to be healthcare professionals. So a medical school for women was started in 1918, and the funds came from American and British Christian missions. The growth was restricted because of his women-only rule for both patients and students. And this is how it started. Women liberation in those days, early days. But in 1947, they found they were not progressing and made two changes. They started taking males, and there was a push to start more advanced departments. In this context, Dr. Jacob Chandy was invited to establish the Department of Neurosciences. He had trained in Montreal Neurological Institute under Winder Penfield, and the first neurosurgery department or neurological sciences department was established in 1949. Dr. Bandev Singh was a neurologist who was practicing in Delhi. He came to visit Bangalore and was so impressed that he stayed on in Bangalore. And the first task Dr. Chandy had was, they will say brain tumors don't exist in Indians. We don't have them. So with his ophthalmoscope, he would go to the medical wards, the pediatric wards, and try to see if there was papilledema, and that is how he found patients with brain tumors who were misdiagnosed as neurosyphilis, degenerative disorders, or meningitis. At this time, there were no diagnostic tests. There was no CT scan, no MRI scan, no carotid angiography. And all you had was pneumoencephalography or ventriculography, where you do a lumbar puncture or a ventricular puncture, inject some air into it, and then the patient would have to go through a variety of convolutions to see the different parts of the ventricle. And depending on the displacement, you will say, well, there is possibly a mass effect somewhere. So this is Dr. Jacob Chandy, and that's CMC Bangalore, where he started the first formal training program in 1958. And Dr. Mathai, Dr. Jacob Abraham were the first things. And over years, it has established itself as a center of excellence. The second place was Madras Medical College, Chennai, and the Madras Institute of Neurology in that place. So it was started as early as 1664, about 20 years after the city of Chennai, or Madras as it was called then, was found. It was a government general hospital. In 1835, it became a medical college. And this is Dr. Ramamurthy, who trained in Newcastle under Professor Rao Botham. He started the second department of neurosurgery in India in 1950, 1 year after Bangalore. And Dr. Narasimhan joined him, and then a variety of people joined, and it became a department of neurology and neurosurgery. Neurosurgical training started in 1959, and Madras Institute of Neurology, a separate building, was conceived in 68 and opened in 72. Interestingly, this was a new place, and yet they got the Nexon frame in 1962 and started stereotactic surgery very early. And these were the pioneers there, the three of them. They did stereotactic procedures for involuntary movements, behavioral disorders, psychiatric disorders, for epilepsy and spasticity. And this is in the 60s when nobody else was doing them. They also started cerebellar stimulation for spasticity with indigenous stimulators. And over 15 years, they performed 1,700 stereotactic surgeries. Now these have been refined, the deep brain stimulation is there, but it became the center for international acclaim. And this is Dr. Kanaka, one of those pioneers doing stereotactic surgery. She is, in fact, the first female neurosurgeon in the whole of Asia. She trained in 1968, and she dedicated her life to academics, research, and mentoring future neurosurgeons. The third center was King Edward the 7th Memorial Hospital, KEM Hospital in Mumbai. This again had an interesting story. The British had started the Grants Medical College and JJ Hospital, the first modern medical institution in Mumbai, in 1845. But there was strong antipathy towards appointing Indians as teachers. And this was the lacuna. So a group of dedicated nationalistic doctors got together and established this KEM hospital in 1925. So Dr. Ram Ginde came to Mumbai after again training at the MNI and started the department in 1951. For various reasons, he left in 1955, and therefore this does not develop into a major neurosurgical center for education till much later. So with the expansion of neurosurgery in India in the 50s to 70s, there were several young general surgeons wanting to know neurosurgery informally, so they went to Bangalore, came back and set up centers there. And then Dr. Bandev Singh moved from Bangalore to Delhi, and the number of centers kept on increasing. And this is the All India Institute of Medical Sciences, started by Dr. P.N. Tandon and Dr. A.K. Banerjee in 1965, and this is where I graduated from. So it kept growing. The number of training centers increased. The modern methods of neurosurgery came in: neuronavigation, neuroendoscopy, radiosurgery, functional neurosurgery, and super specialized branches came in. And this is the current training programs. We have the 3-year post-surgery training program and the direct 6-year program after your graduation. So we have 113 centers training 404 seats. We also have a parallel diplomat of national board exam, where again we have 175 seats. So at the moment we are generating 580 new trainees every year. Let me come to the Neurological Society of India. Now this is the main society, and in December 51, the two people from Bangalore, Dr. Abraham and Dr. Bandev Singh, and the two from Chennai, Dr. Ramamurthy and Dr. Narasimhan, 4 people met over dinner and decided to form a neurological society. And they had the vision to bring all disciplines of neurosciences under one umbrella. So this was in December 51, and these were the 4 stalwarts. And 3 months later, they had their first meeting. From the conception of a society to having its first meeting was just 3 months. And they had 30 members, And the first presidential oration was aptly titled, Neurology Comes to Life. And at that time, a few years later, they decided to start their own journal, Neurology India. So some pictures of these stalwarts. The initial meetings were held with the Association of Physicians, and from 1964 onwards, they had their own meetings. And they decided to have subsections of neurology, neurosurgery, neuropathology, and neuroradiology, which is unique. There's so many branches coming together under the heading of neurosciences. Clinical neurophysiology was added. Knowing the importance of the neurophysiological technicians and the neuronurses, they were also added. Education was always a priority, and they had working groups on medical education and training and research. And in 1977, they started the Continuing Medical Education Program. This was the first specialist society to start this education initiative. And they would bring out the proceeds in terms of a book, Progress in Neurosciences, every year. They were active in the international stage. The Asia-Australasia Society of Neurosurgeons were formed in 1967, and you can see Dr. Ramamurthy in the corner. The Asian Congress of Neurosurgeons was started in 1997 with India as a member. And 1989 was a landmark year for the NSI, or the Neurological Society of India. We had 3 international congresses that year, all held in India, on neurological surgery, of neurology and epilepsy. And we started having friendship meetings with various societies all in the world. And this is our current membership strength in the NSI. We have 3,100 total members, majority of them neurosurgeons. We have about 1,000 associate members in training and roughly about 4,100 total members. We have a board of education which looks after all the educational activities. They hold foundation courses or boot camps twice a year for new trainees. They have instructional courses twice a year for final year trainings. They have online OXI tests for exam-going residents, super specialty CMEs for people who just finished their training, and have webinars, master classes, journal clubs, symposia, case-based discussions, a virtual OR. And this all got a fillip during the COVID, when we didn't have physical interaction, but the educational activities continue. They also bring out a newsletter, Current Practices in Neurosurgery, talking about controversial topics and what the consensus is in the relevance of India. And this is the type of things that they bring out. Neurology India is the journal which has been there for a number of years with an impact factor of 2.2, and it's increasingly accepted. We get a large number of international articles also. So what are the challenges? India is a large country with a wide variation in the available resources. We have several very advanced centers with all facilities which can compete with the best centers in the world in terms of quality and output. But large parts of the country still have limited resources and limited neurosurgical services. And this divide is there in the urban-rural setting. So we have to develop a resource-restrained and a cost-effective service. We cannot blindly follow the Western pattern because it is just too expensive and won't cover the large amount of a population. We need to standardize the neurosurgical care with good basic neurosurgical care in the periphery and advanced centers at some places, so the hub and spoke model needs to be strengthened. And we need to widen the availability of neurosurgical care, so even in the remote areas, immediate care is taken, especially for patients with trauma. And we need to improve the pre-hospital care for trauma patients. There is a wide variation in the quality of training. We have to standardize this. The NSI is working with the National Medical Council to have common standards in assessment. And the NSI was becoming an own boys club, so we had to change a course correction so as to make it more inclusive, and the younger and middle-level members are more involved now. We have a partnership with the Congress of Neurosurgeons here. So what do we have in common with them? They both started in 1951. The major objective of both the organizations is education. Both the organizations work on strong democratic principles, and we are the largest democracies in the world. So it is natural that we gravitate towards each other and work together. And the American Association of South Asian Neurosurgeons, ASAN, of which Jogi is a well-known member and one of the prime movers, he played a major role in bringing the two organizations together. The CNS invited NSI to participate in the meeting in 2009. It was a hugely successful meeting. Over 50 Indian neurosurgeons came, and our past president, Dr. Abdul Kalam Azad, gave an invited talk. In 2014, we had a signing of an MOU between CNS and NSI, which was renewed in 2017 in Boston. And now every year we have regular participation by the president and secretary or the nominees of NSI in the CNS meeting and vice versa. We have joint workshops, we have joint webinars together. And this MOU was renewed in 2022. So what has been the impact of Indian neurosurgery on the global stage? There have been numerous clinical and research advancements in craniovertebral anomalies, encephalocele, tubercular meningitis, tuberculomas, parasitic infections, fluorosis. There are Indian contributions towards understanding epilepsy and the surgical treatment of epilepsy. The pioneering efforts in stereotactic and functional surgery, including deep brain stimulation, and numerous research and clinical publications on a variety of topics. And one advantage India has is a large population. So we have large numbers of whatever disease you want. And that has been the reason why we have a large number of multicentric studies. So the positives of Indian neurosurgery, we had highly advanced surgery and neurosurgery in prehistoric times. And then we went back, and after World War II and after Indian independence, there has been a rapid development. We started late compared to the world in modern neurosurgery, but we caught up with the best of the world. And we have luminaries who stand out in various sort of subspecialties all over neurosurgery. One basic difference between the development of world neurosurgery and Indian neurosurgery. In most of the world, neurology and neurosurgery developed independently in the medical and the surgical paradigm. And there's always a bit of friction and competitiveness between the surgeons and the physicians. So that divisiveness and fragmentation was there. A unique aspect of Indian neurosurgery is the collaborative development of different branches of neurosciences right from the beginning. When Vennore started as the Department of Neurological Sciences, Chennai was a Department of Neurology and Neurosurgery. And we've grown up together. Even our society was common till very late, recently, when they have got a separate society, but we still collaborate. So this collaborative development is something which has helped us in moving forward. And this collaboration with our neurology colleagues, we may fight with them, but we have dinner together. So this collaboration with a large number of patients due to our population is the biggest strength of modern Indian neurosurgery. And I'm happy to say that despite our late start in modern neurosurgery, we have come up to world standards. Thank you for your attention. Jai.
Friends, I know we're running a little bit late, but we got a little late start. Having been to India 60 times in the last 3 or 4 decades, I have been privileged to watch my friends bring it to the world stage. I'll speak to Dr. Razak in the back. Decompressive craniectomies were done 20 years ago over there, where we were still waiting, and we learned from them. I learned selective motor fasciculotomy from there. There are things that we can learn from around the world, having operated in Uganda, Ukraine, India, etc. In India, as you mentioned, sir, with 15% of resources, they do 85 to 90% as good as we do. And friends, many of you, if lucky, will have the opportunity to go there and learn and watch. In 1 month, you will see more than you'll see in 1 year here. I have seen stalwarts do 400, 500 cases of something where I have been fortunate to do 25. Dr. Ross, thank you so much. On behalf of College of Medicine, Sonia, on behalf of Samosa, thank you. I know we're running a little late, but we do have time for questions. If you're willing to stay, we can have some questions. If Sonia or somebody would pass the microphone around.
Yes, just please speak into the mic if you're asking
Raise your
a
hand
question.
and somebody will bring you the microphone.
Just
One back.
test.
Hello. I just wanted to ask what types of opportunities there may be to go to India, like you were saying, and see surgeries, and at what part of our careers can we really look into doing something like that?
So we have a program where we do welcome students from outside to come for some observership. Because of the sort of rules of the medical council, we can't offer you a hands-on experience, but you can certainly assist in our cases, be in the outpatients, look at the wide variety of cases that we have, and sort of see how we can do reasonably well in a resource-constrained environment. For example, epilepsy surgery, we started in 1997. And I came to UCLA to look at Pete Engen's unit to see how it is done. And I went back totally deflated. We never got these resources to do it. And then we sort of started and we found how we could, amongst the different cases, how can we identify cases which we can easily pick up and get good results. So you would get a good exposure. I mean, the Neurological Society of India has programs where we can have exchange. And the ASAN here in the US, that's the Association of South Asian Neurosurgeons, also has a program where they sponsor people to come to India and give, maybe a 2 to 3 month experience there. So it is possible.
Yeah. So that's also a question for us, right? We at the India Center are trying to create more and more opportunities for our students across the board. So India Center is very unique. At UCF, it answers to the entire university, including its 70,000 students. But you're right. I think India is 1.5 billion people. It also means it's 1.5 billion challenges, but that also means it's 1.5 billion opportunities, right? So we are trying to create more and more opportunities, and something will come up. There is something in the works right now to have an education trip for UCF students for a couple of weeks to India. So hopefully we'll get on that. But thank you for asking that question. That's the motivating factor.
If you're interested, we'll make it happen. Okay?
Thank you very much for your time, sir. I just had a quick question. You mentioned that Susruta emphasized heavily sterilization of his equipment and tools. And I was wondering, was there any cultural or scientific justification given? I'm wondering if he had developed some sort of germ theory.
For the trepanation?
Sterilization.
For
sterilization. Equipment.
In the olden times.
For his equipment sterilization, instruments.
In India currently, we have ETO2.
No. Susruta, how did he maintain sterilization?
Right. So I wouldn't be able to give you a direct answer, but heat is something which they would use very often. So flaming the instruments, sort of making it, getting the temperature high so that the germs die off. This is something which was very commonly used by those people at that time.
Thank you.
Thank you. It's more of a comment. The last non-fiction regarding medicine I read was The Emperor of Maladies by Siddharth Mukherjee. I'm also kind of a historian who looks at why states develop complex weapon systems and put them to battlefield. So I see a good history. It's a great history. Are you thinking about writing a non-fiction on the history of India's neurosurgery?
Thank you.
Are you thinking of writing a book?
Not. I'm too busy with my clinical work to sort of devote time to writing. As you know, because of our workload, we are sort of really working morning to evening, 6 days a week. But yes, there are treatises available, and Susruta, the ancient Ayurveda, there are texts and English translations which are available. And it's amazing how much they were able to do and how similar that is to what we are doing today. So that similarity of the ways of doing it. I mean, if you look at the different ways of surgical techniques, they're listed. I mean, practically everything is there. So it's amazing how those people could envisage and do all that at that time. And the use of anatomy at that age, at that time, is something remarkable. I mean, the science came much later, but it was being done then.
If I may make a comment, friends. I trained here. I went to medical school in Galveston. Like you guys, in 1977, I was sitting in here like you guys. And over the years, I had the opportunity to go back and forth and travel the world. When I go to India, for example, Dr. Rezak, I can mention, they did gamma knife 4,000 cases, where here, the people teaching us were doing 1,800 cases. I would go there, and in one hallway, you would see enough cases that you could accumulate in about a year's worth of training. Just by walking the halls and seeing and learning, you'll see the commitment and the dynamism and the energy, and most importantly, the understanding of what's happening to each patient, and you'll become a better doctor. The world is becoming flat, and all of you do have the opportunity to travel in your third years and fourth years. Dr. Ross, you're managing some of that, and Dr. Danish Bhatti is managing the neuro block, so you'll have opportunities. But through the India Center and through various other opportunities, we can put you in various places with Dr. Singh and other hospitals in the country, not just India, other parts of the world. I'm also on the Foundation of International Education for Neurological Surgery. We can do that.
Thank you again for your presentation today. I have a question about what do you think us training in the U.S. Like medical system could learn from the doctors and the people training in India as well, like right now, in this current day?
So what the Americans can learn from here? Or sorry,
what can we as trainees learn from how medicine is taught, and also how trainees learn medicine in India today? What's like one or two like things we can take away from the difference in the system?
So one basic problem here in US is the costing of medicine. I think that is one big challenge. And over the years, it has become more and more expensive. There are medical legal implications. There are set of systems that where not a redundancy in the system is required to make sure that any given patient is given the best care, which is a very laudable sort of thing. I mean, the principle is absolutely correct. But it does add to the cost of medicine. And unlike US, in India, most of the medical expenses are borne by the patients directly. Insurance is coming in, but even yet, it's a small population which has the insurance. The government is chipping in with some degree of medical insurance for the people who are right at the bottoms of the society. So free medical coverage is there. But even then, just the cost of medicines and things are quite prohibitive. So as a doctor, as a surgeon, even though I work in a private hospital, I still have to have that concern about the costing always at the back of my mind. In neurosurgery, 5 to 10% patients will not do well. They will have problems. That's universal. And if the hospital stay goes beyond what you projected, then it becomes very difficult from the family. So that is something where we have cut corners, but the cutting of corners has to be done in a way that we don't harm the patient. So, it has to be, like when we started epilepsy surgery, we said, okay, we don't have the VADA, we can't do it. Or, the disposable grids to do the electrocorticography. They're supposed to be disposable after one use. And each one of them had cost about $1,500 to $2,000. That's more what I would charge them for the surgery. So, we have to improvise, and that is something I think we can sort of share, and, you can learn from that. But obviously you have to modify it to your local milieu. What would work in India may not work here. So, we have to customize and we have to modify things.
Anybody else? I'll make a point to your sir. I was taught this early in my medical school. Don't order a test unless you're going to know the result of it before you order it. You will be trained and you will be told by many mentors like myself and others to order a battery of tests to look for something. That's foolish. Do you all know what the word idiopathic means? What does it mean? What does idiopathic mean?
You don't know.
It means this idiot doesn't know the pathology. Okay? So here in this country, to your point, we order a battery of tests looking for something. That's BS. You should think and order the test when you need to, as Dr. Singh just mentioned. Be cognizant of the patient's and somebody's wallet is eventually yours and your neighbor's. So good point, but there's a big difference. There, I have learned that the young trainees have a way of thinking, like my wife was trained in India. She's a hell of a lot smarter than I am.